in this field. So today's topic of discussion is crowding and its management. One of the very common thing that we see, but least bothered or neglected part in dental practice, especially with respect to general dental practice. So crowding, there is a relation in the picture and what you see there. It's a crowding. So somebody want to fit inside, somebody want to try to fit inside, push it inside, no space, so he's moving out. So that is what happens in a dental arch. And what are we going to do? So this is purely a clinically based oriented topic: how to identify, how to diagnose, how to plan your practice with respect to this. So let me start with a simple example or a clinical scenario. Let us start with the clinical scenario. I'm going to put a patient in front of you who has been coming into a clinic very since 4 years or 5 years. Now suddenly the mother is worried about it. Mother is suddenly calling you for an appointment, asking, doctor, I want to see my daughter. What happened? What happened? I think is teeth are coming inside. There is some primary teeth are still remaining there, but permanent teeth started coming inside. Today morning I was brushing her teeth and I could say I did not see till now. She didn't ever told me. Now when I saw her mouth accidentally while brushing, I saw some whitish color inside. And when I observed it, there is a teeth coming inside. I was so much worried and tense, sir. I want an appointment from you tomorrow. Can I see that? I said, okay, fine. You come. You come for the appointment. So we are given the appointment and the patient comes. The patient's age is 6.5 to 7 years of age. Is in your clinic. And this is the situation. So in the telephone, when they said, she was so panicked, she was so worried, tensed, that teeth has come inside, something whitish color come inside, sir. What is that? Isn't it the time to come a teeth? How can it come inside? It won't hurt the tongue. It is inside. So many questions we used to get from their mother or a parent who is really got tensed and worried about the situation. So when you see this situation, oh, okay, this is the situation. Fine, fine, fine. Okay. So what will be your treatment plan? Can you come to the chat box who are in the Zoom or in the YouTube? Can you come to the chat box and say, what will you do for this condition? Yes, Rishba Kabur, extraction of 7-1 and 8-1. Yes, extraction. Great. I mean, the answer is very evident. Extraction of extraction. So, I mean, it's around 6.5 to 7 years of age. Teeth has come inside. So, the only option is we have to go for the extraction of the primary central incisors, lower central incisors. Okay, 7-1 and 8-1, we have to go for extraction. So, now automatically the mother will be asking one question: sir, it has come inside. Will it come outside? Will the tooth will come outside? So, the answer to this is, oh, don't worry, it will come. Tongue will push it. Tongue will push it out. It will come outside. That is the automatic answer that we give for the patient's mother. Oh, parents will be very happy. Mother will be really, oh, yeah, okay, okay, fine. Tongue will push it inside. The child will be observing and listening to this, and he will start pushing it. You know, he will literally start pushing it. How he will push like this. He will start pushing it, pushing it, pushing it. He will start pushing it. Believe me, tongue has got a function of pushing the teeth. Is there? Please go into your Chaurasia or go into your Graeber's anatomy textbook. See whether the tongue has got a function to push the teeth. I don't think so. Tongue doesn't have any function to paw on a teeth and push the teeth. So by 9, 10, 11 years, you can see this. You can see this. Who induced this? God only knows. I'm not saying that we induced it, but we set a terminology. Don't worry, tongue will push it. Don't worry, tongue will push it. But you know, this guy was very, very genuine. This guy started pushing and pushing. Within 3 to 6 months, he tried to push the central and lateral. Somehow he made that lingually erupted central into almost in this kind of situation. And within a year time, Now the mother is again, he has did a very good job of pushing that central into perfect alignment. But now another problem is coming. He did a good job, but another problem is coming. The lateral is getting blocked out. Now what we should do? Now the mother is again standing in front of you saying that, sir, that he has done, sir. What about the next it? Will the tongue will again push this out, sir? So what answer we should give to that? How we will manage this condition? You know what has happened in this condition is ostrich philosophy, you can say. This is one kind of animal, whenever it whenever it faces a dangerous situation, a very unknown or a difficult situation, it puts its head inside a sand and say that I'm not seeing anyone, so nobody is seeing me. It believes that. We are in our own clinic and patients, we are educating the patient. We dentist, every time when we talk to the patient, we are educating the patient. So we think that the patient believes us. Whatever I say, I'm an ostrich, I'm the big boss, I'm the big guy. Whatever I say, patient believes it and they follows it. Yes, there are some people who follows it, but not all the patient that you see in there. They will search. Nowadays, Google doctors are there. There is every building, there are multiple dental clinics are there. Walkable distance and appointment based practice, everything is happening. So while they're coming down the staircase, the next floor, another fellow is sitting with a beautiful dental clinic. And why can't we show my daughter into that clinic? Let us just see. Let us take an opinion now. What is going to happen? Anyway, we have come for a consultation. On the way, another dentist is waiting. Let us show him and let's hear his opinion. Whether he says the same thing or not, no idea. So this is called ignorance is bliss. You believe that patient trusted you, taken for granted. Yes, done. Ah, tongue will push it. Don't worry. You come after some time. You will say, yes, I will do that. That is ignorance is bliss. That is not this world we are living it. We have to change our attitude for that. Because whenever this kind of difficult situation, I'm just putting one situation. Yeah, today I'm going to talk about crowding. One situation I just want to talk about. Whenever this situation comes, we also does the same philosophy. We dig our head inside. I don't know. So, but I just manage somehow. My junior dentist managed somehow. Yeah, the parents I have made happy, doctor. How did you? We never asked. Oh, parents are happy? Fine. That's what you believe. But when they walk out of your clinic, they are going into somewhere, taking a second opinion, third opinion. Yes, because their son and daughter it is very valuable for them. You are not valuable. They are valuable for them. Kids are valuable. They are the center of attraction, center of everything in the family. They will do anything for their kids. So they will take opinion. Second, third, fourth opinion. I have seen 12th opinion also have come to me. 12th, believe me, 12 clinics they visited. 14th or 13th is my clinic which they come. So do not trust on that factor. They will take opinions. So crowding. One of the most, let me tell you, this is in parents. In parents, this is one factor which they get worried, tensed, panic, disturbed, doubtful, they will come. Because especially the lower anteriors erupt first. Even for anteriors come, central won't be erupted, upper central won't be erupted. That is why I put this slide first. Even for anteriors are crooked erupting, but upper still primary teeth will be there. They are not worried. They are worried about the lower. Why it is coming there? Lower anterior crowding. One of the most common clinical scenario you can see in your clinical practice is the lower anterior crowding. Many cases. You can say around 7 to 8. I am say 100, 10 out of 10, but 7 to 8 cases, please. You might be seeing some amount of crowding. I'm not saying severe, some amount of crowding will be there. But 2 to 3 cases, perfectly aligned, nice arch is also there. So why there is a disparity? There is crowding in one, there is no crowding in this one. Who is the reason for that? The easiest way to escape from this as a general dental practice is that we will ask the question for the father and mother. Do you had a problem? Do you had a 4 extraction? Or do you had this problem? Yeah, yeah, my tooth is, oh, okay, okay. Those are family run. Family. In your family it is there. So what your side also will have. We easily escape by putting the burden onto the family issue. We never think beyond that. We dentists never beyond. I asked last question of my is hereditary factor. But much, much before that, I'm going to discuss today is that. So lower anterior crowding is a very common situation that we see. So which cases should I treat, sir? Why it is happening, sir? Why that lateral is coming inside and outside and rotated and tilted? Why it is coming? We are going to discuss that in the lecture. So if lower is done, then comes the upper. Look at the picture. Upper centrals are crooked. According to the parents, they are crooked. They are twisted, turning over. When they say this problem, we only focus on to the particular tooth which is erupted. That's it. We won't see anything beyond that. As a general dental practice, we don't see anything beyond that. So this is the upper arch of a patient who says that teeth are crooked. It goes on when the lateral comes, lateral also either buccally or tilted or rotated. It comes, then goes for the next is the canine, no space, canine is bulging out. It's coming out of the arch. And 13, 14 years, 15 years, it's all out. There is no space for that canine. It's a sequence that has happened. So who is the one guy who's affected here is the canines. Clinically, if you see, the guy who affected is canine. But when you see that, you are very happy because you know, okay, I can correct it. I can correct it. I can bring, because you never extract the permanent canines, right? So you remove the premolars and you can easily bring the canine into that position and you can solve the problem of the parents. Their worry is a crooked teeth. So you can solve that. The upper anterior crowding is another issue which we very commonly see in the clinical situations. And one guy who is always been blamed till now is that canine. That canine doesn't have space. He has come outside. He has come inside. He's blocked. Let me bring that, put the elastics, put all those things, bring him into the arch. So there is no space. So what shall I do? I have to remove 4 premolars so that I can nicely bring him into the arch and make the parents happy, everybody happy. That's it. But let me tell you, you are doing a good mechanotherapy. You are doing a nice alignment and finishing of the case. I do not say anything about that. But let me tell you, this doesn't happen in single day. It is happening. It's a recurring meeting, you can say. It's keep on happening. It doesn't happen in a single day. It was happening in long time. The incisors, well, the erupting, the canines were there. They started pushing the incisors. Both incisors started pushing the canine, and it didn't have any space in the arch. It came out. The question is, why the canine has come outside? Why both incisors are perfectly aligned or whatever, but why the canine doesn't have any space or impacted or rotated or palatally buccally placed? Why is our solution? We have to find out. We dentist has to find out. Parents are not worried about it. We dentist has to find out why that guy is always getting blocked. So this guy, canine, get blocked inside or no space to come inside. If you look into the arch, there are no crowding, but there is no canine there. Without canine, without space for canine, how can you say the arch is not crowded? It's a totally collapsed arch. Can you come to the chat box and tell me where is this canine of this patient? Okay, where is the canine of this patient? The canine of this patient is sleeping. He's going he's nicely driving through the NH 49 or whatever, nice in through the mandibular canal. The canine is driving, sleeping nicely. We had hats off to the surgeon who's going to open it up and doing that surgery without injuring that nerve which is very close to the inferior alveolar nerve, because it is through the canal it is going. In the reverse way, it is going. So, no. And orthodontics is going. Orthodontics is going. So, what has happened? What has happened? Why it has happened? In an arch, if you look, it is perfectly aligned, nice, and everything, roots, everything, if you see, fine. But there is some guy who's missed there. Why it has happened there? So why this happens, or canine gets blocked out, or crowding that is happening, and how we can manage it, how we can remove this session that we're going to do. So first indicator for crowding, let me tell you, you don't need a CBCT, you don't need any X-ray, you don't need anything to tell a patient that your son and daughter has got a crowding that is a risk happening. If you see a depth of a cavity, you can say that approximately there's a risk of filling this. You will tell the parents without an X-ray, you will tell that there is a risk of filling this because it looks deep. There are symptoms and signs which you have already taken, like pain at night, mobility, or anything. The depth of the lesion, number of surface involved, which gives you a hint that this is not going to be filled with a temporary or not. Exactly the same way, without an X-ray, you can tell that. Exactly without an X-ray, without anything, there are indicators, there are methodology to tell the parents that, see, your son and daughter is going to get some amount of crowding, some amount of problem. It's a going to happen. What are they? What are they? What are the clinical indicators without an X-ray? Let me tell you, without any IOPA, any OPG, you can tell to the parents from tomorrow saying that fine, there is a problem. So I'm going to put some picture. This picture, you have to observe the picture and come to the chat box and say, what is it? Okay. This is a picture of a 5.5-year-old child. What you see in this picture, can you tell me anything usual or unusual in this picture? Can you come to the chat box and tell me what is that? Usual or unusual? Great, great, fine, great. Yes. So with respect to our topic of discussion today, there are no space. In primary dentition, mandatorily there should be some space, but that is not there. There are no space in the primary dentition. Now, what about this picture? Can you see that? The difference in this picture, there are spaces. It is inevitable that primary dentition should have spaces. That is mandatory, that primary dentition should have spaces. That's an investment done there. So now let us go back to the case which I presented to you, where the lingually erupting central incisor, you all said what? Remove the 7-1 or 8-1, right? Nothing wrong. But did you observe before extraction? Oh my God, already there is a crowding in the primary dentition. Already there are no spaces in the primary. Forget about the crowding here. Forget about the crowding. Are there any spaces in the primary dentition? You did not observe. You did not observe. You removed the primary central and you said tongue will take care about it. Don't worry. It's like a cycle, you know, it's like a winded cycle you heard from your seniors and you're just following it up. So look at in this arch, there are no space there. To into this patient, how can you say that? So spaced versus non-spaced primary dentition. Dr. Baum, amazing literature to read. Search for it. Dr. Baum's 50 to 60 patients he has studied, and he found out that this is something real problem, and he came out that spaced dentition is class 1 and non-spaced is class 2. That is a tough task that can have problems. Non-spaced primary dentition can have a problem. So what he said, another study, what he said is 7 out of 10 cases where there are no spaces in the primary dentition can have crowding in the permanent dentition. 7 out of 10, that is 70%, you can say, can have crowding. You can't say this dentition saying that don't worry, nothing will happen, the tongue will take care. No, you can't say that. And in crowded primary dentition, 10 out of 10 can have crowding in the permanent dentition. So now, am I justifying you telling that tongue will take care, tongue will push is not justified here? That's not the right protocol. As a general dentist, you're supposed to do that. And what about space dentition? Again, if there are more than 3 mm of space, 5 out of 10 cases will can have crowding. If there are around 5 to 6 mm of primary spaces, primate spaces, physiological spaces, whatever spaces that is present, if there are around 5 mm or more it is there, then you can leave that arch untreated. There will be no crowding in the permanent dentition. But if the spaces are less, chances of crowding are more. To make it very simple, the less the spaces in the primary dentition, the more chances to get crowding in the permanent dentition. What is this condition? Can you come to the chat box and say, what is this condition? What is this condition? All of you, can you get come to the chat box and say what? Yes, around 230 people in the Zoom are responding with yes, nursing board to caries, ECC. Thank you so much. Yes, ECC. Thank you so much. So whenever this condition comes, our response is again, oh, it's a milk teeth, it's going to shell off, it's going to fall off, we'll remove that and remove that. That's what. It's a front teeth is affected, don't worry, nothing's going to happen. But let me tell you, that's not always the condition. It always spreads. Whenever ECC or nursing bottle caries appears, even if it is a mild form of nursing bottle caries is there, believe me, it doesn't stops in the anterior segment. It goes and involves the posterior segment also. So what happens if the posterior segment, epidurodontist can come into your clinic and he can nicely do a pulpectomy or a pulpotomy or whatever it is, I can give us full crowns, that is well and good. But what happens is the mesiodistal caries of the primary teeth can eat up a lot of spaces which was naturally present. There was spaces present. Many times we hear when her teeth was coming so nice, cute little tiny bunny little teeth was so nice it was. Then all these problems started, fractured, fell off, tooth got fractured. All those comments we used to hear that. So front teeth was their worry, but when we open the mouth and see back teeth is totally mutilated, mesiodistal caries have completely destroyed the spaces which they're supposed to preserve for the permanent teeth. It's gone. So the permanent teeth can just shift inside, just shift and come forward if there are no primary teeth, which are the natural space maintainers. So MOD caries, very important, very important. If there is MOD caries, you have to restore with a proper contour and contact. If not, stainless steel crown would be the best, so that it can preserve the MOD spaces, which are spaces required for the permanent teeth. Otherwise, you will end up in total disaster. It will increase as the child grows, it increases. So premature loss of primary tooth or mesiodistal caries are one indicator. You don't need an X-ray to see that. It's already, even if you're doing a space maintainer for this child, even if you're giving extracting the root stem and doing a good caries management for this child, tell them that your son and daughter can have a space problem. I want observation. I want some prevention so that can happen. Tell them and inform them. Prevent the orthodontist comments that way. And retained deciduous teeth is another problem that can cause crowding because they have not moved out. So the primary teeth has not moved out or shed off at the right time. So what will happen to the permanent teeth? They will shift. They have to shift another position, which can be usually lingually or palatally. Usually lingually or palatally, very upper side, very most commonly labially. It has to come outside. That starts another problem there. So retained deciduous teeth. timely shedding of deciduous teeth is very important. Look at here. Perfect. Everything is perfect, but that canine is not ready to move out, not ready to go. So what happened to the prime permanent canine? It moved outside. It moved buccally and it has come outside. So in this kind of situations, delayed exfoliation of a primary teeth is another reason that can happen. So you have taken OPG. You have to take an OPG. What is happening there? Both side, upper, lower, what is happening there? You have to predict and you have to decide what is happening there. Now, all of you, can you come to the chat box and say what kind of appliance is given onto this lower arch? This is around 12-year-old patient. Some lower appliance is given. Can you identify this appliance and come to the chat box? What could be this appliance? Mandibular microexpander, Hyrax, mandibular expansion. Good, good, great, great. The earnest doctor, the sincere doctor want to save that premolar, so he want to expand the mandibular molar with a Hyrax appliance or whatever. Either he want to do it by a rapid max expansion, a protocol of a slow maxillary or slow max, rapid max expansion. You want to get some kind of expansion. That's what he want to do. All of what you said is right. But you know what has happened? Let's see this. Let's see this patient. Let's see this. The same patient is closed lips. I asked this patient to seal or close naturally to seal the lips. Can you see something that is happening? Can you come to the chat box and tell me anything can you observe in this patient? Anything can you observe in this patient? Good, good. Yes, that's great. That's great. He's closing, but there is a forced closure. There is a too much of force of the mentalis muscle, you can say that. So do you think that expansion that doctor is trying to do will be solved or resolved? No way it could be resolved, because there is somebody is acting against the force we are applying it. We are looking into the arch. I want to create space. Let me expand it. Let me bring it out. Let me create space. But there is something else in the nature is acting against that. Do you need an X-ray to find out this? Tell me, you need an X-ray to find out this. Soft tissue here, soft tissue, lips, or the perioral muscle is acting here. Do you need an X-ray to find out this? None of the cases which I have told, you don't need an X-ray to find out this. So this is what I'm going to, this perioral muscle is hyperactive. So crowding condition, one of the simple clinical observation that you want is the perioral muscular activity. We never see that, especially your mentalis muscle. Powerful muscle, yeah. Just go into net and search the amount of pressure exerted by mentalis muscle alone onto your chin. You will be amazed to see that. Mentalis muscle, it exerts a huge pressure onto the pogonium or the chin area. The symphysis doesn't allow the mandible to expand, and you can see crowding happening there. You can see crowding happening there. There will be lower anterior crowding there. So lip strain while swallowing, orange peel, or golf ball appearance. These are technical terms. If anybody is giving a NEET exam or any kind of exam, you can see this question like this: orange peel appearance of mentalis is called like that. Blah blah blah. I'm not going into that, but no, it's all viva questions or exam point of view. But the constriction of the mentalis and the perioral muscle put a pressure onto the anterior component of the dental arch, making it constricted, doesn't allow to grow. So look at the, observe this perioral muscular activity here. You can see the patient is saying the word M and swallowing it, and you can see the amount of perioral muscular, the orange peel appearance, the golf ball appearance, whatever you name it, you can see such an activity is there happening, and the upper and lower and the crowding is inevitable to happen into this. So do you need an X-ray to find out this? No need. Simple clinical observation, you can find out this. Definitely habits. Next come to habits. your thumb sucking habits, your lip biting habits, nail biting habits, mouth breathing habits, all these habits can also cause your crowding condition, which also doesn't require an X-ray. Okay, an IOP or your OPG is not required for these conditions. So these are the simple clinical indicators you should observe before treating a crowding condition. Or if the parent says that my son's teeth are coming inside or not coming, whatever they say, this is a general dentist should observe into these conditions. And finally, one more thing which if I don't say it won't be complete is the tooth size. There can be tooth size which is abnormally large. The mesodistal width of the tooth is too large. But how you know that it is large? There are so many diagnostic protocol to be seen that. Okay, you have to really see a diagnostic protocol to see that. But that is also one condition that can cause crowding. The base of the arch is very small and tooth size, mesodistal width of the tooth is very big. Sometimes you can see huge one side central incisor, sometimes both side lateral incisor is abnormally large. Second premolar is big. You know, those variations can also cause crowding. So that is called tooth size arch length discrepancy. Tooth size arch length. Once again, tooth size arch length discrepancy. When the pure morphology of the tooth, the size of the tooth, the shape and size of the tooth are abnormally big compared to the space provided in the arch, you call it as a tooth size arch length discrepancy, and mostly it is hereditary nature, family. So I told you, last question I asked them is, sir, now let me tell you, what is your condition? Did you had a orthodontic treatment done? Yes, sir. What? How the orthodontic treatment? How many months treatment? How it was done? Any tooth was pulled out? You know, a lot of questions comes there. Then they say, my grandfather also had, father also had, I also. No, it will flow like that. That's the last thing that you should do. So majority of things are local factors, which I already covered. Local simple factors which doesn't require any of other diagnostic protocol. One protocol is called functional analysis, or just look into the patient nicely, like non-space primary dentition, mesodistal caries, early loss of primary teeth, retained tooth, soft tissue dysfunctions, hyperactive mentalis, and habits. That's the most common thing that we see. Now, management. Now coming to the another part is called management. How can you manage these conditions? Crowding and its management. How can you do that? So one of the most important thing that you need to do is, you provided of the soft tissue problems, whichever problems that you have done. Next thing is the model analysis, mixed dentition model analysis. You have to learn. So in this, you have get a definitive idea what is the reason that is happening there. So model analysis is important, which gives you the amount of crowding present in an arch. It gives you the palatal height index, which is again very important. And it also gives you transpalatal width, TPW, transpalatal width, which decides your treatment plan. So this is something diagnostics protocol which you have to follow, read and learn. Now, when you should do this analysis, okay, which all conditions you should do analysis, every cases should I do? No, not every cases. When you should do, when you feel, when you look into the cases, whether the functional problems you identified is there, plus a crowding you can see. A rotation of a single tooth or lateral incisor is rotated or tilted, whatever. If tooth is delayed in eruption, not coming out, canines are still there. Laterals are gone 1 year back. Still the permanent laterals have not come. Only the two centrals have come. Permanent laterals have not come. Delayed eruption or delayed exfoliation of the primary teeth. Then I think you should go one step ahead of doing this analysis. Not all cases where everything is perfect and fine, but when you're planning with this, these are specific conditions where you should do a model analysis. Early exfoliation of the primary teeth. Primary teeth is exfoliated early. You don't know how much space is already lost or how much space is available for the unerupted teeth. So those conditions are where you need to do a model analysis to be done. So once you do the mixed dentition model analysis, you'll come to a definitive diagnosis saying that, okay, this patient is having a minor crowding, can have a minor crowding. What is that minor crowding? 3 mm, up to 3 mm discrepancy per arch, fine. Moderate crowding, 3 to 5 mm per arch, fine. Severe crowding, greater than 6 mm per arch. So we categorize crowding into minor, moderate, and severe. So what will you do if you find out a mild crowding in your patient, in a mixed dentition patient? What will you do? You can leave the arch untreated also. Up to 1 to 2 mm, you can leave the arch untreated. But let me tell you, one missing thing is, don't tell the patient you come at 13 and 14 years. Periodic monitoring, follow up is required. Every 3 to 6 months, let them come to your clinic. The first child, after 1.5 years, the mother will have a second child, right? So don't worry, you got a new patient because you have been continuously monitoring it. They have cousins, they have brothers, they have neighbors, they have friends also. So don't worry, let them come every 3 to 6 months. Let them be in your clinic. At least you will be packed in your clinic in afternoon session or whichever session is there. So periodic monitoring is very important. Premature loss of primary teeth. If there is a premature loss of primary teeth, you have to interact when crowding is present, either with whichever type, space maintenance, lingual, passive lingual arch, or a nance palatal arch, or a band and loop space maintenance. You have to read more about that, but some kind of space management is required if premature loss of a primary teeth is there. Otherwise, if everything is perfect, no mesodistal caries, no space loss, but still I suggest you, if you find out 1 to 2 or 3 mm space discrepancies, keep the patient monitoring. If MO distal caries are there or premature loss of teeth are there, act immediately. Give a lingual holding span or a passive lingual arch or a space, your band and space maintenance, whichever is required for that. Now, I just want to show you a picture of a 9-year-old with a crooked teeth. A patient is come with a mother and she is 9 years of age with crooked teeth. So we started taking the history. Patient complaint is a crooked teeth. We started taking history. On history, we revealed patient is having a tongue thrusting habit. But when we saw that space deficiency is only mild to moderate, that's it, mild. There's no severe space discrepancy, mild amount of space discrepancy, but patient had a problem called tongue thrusting was there. So should we do something? Can you come to the chat box and say, should we do something? So this is in front of you, a child of 9-year-old with a crooked teeth. Patient have mild to moderate space discrepancy at this point of time, but they have a tongue thrusting. She's having a tongue thrusting. Crib, tongue training, crib. Good, crib. What was said and done? With analysis, with the diagnosis, I came to the conclusion that I have to intercept this child. So started with an appliance called myofunctional appliance. Started giving a myofunctional appliance. Patient was cooperative, parents was cooperative, educated, they want to do something, myofunctional appliance. Within a year time, I could see the resolvement of the anterior crowding, tongue thrusting went off, open bite went off, everything went off by itself. A natural alignment of the teeth has happened. So even if you find a patient with mild crowding, please do not, parents doesn't know tongue thrusting, yeah. Parent will never come say that my son and daughter is protruding the tongue is thrusting. Nobody will come in front of you in clinical practice. You have to diagnose it. So I diagnosed here that child is having a tongue thrusting and mild crowding, slowly going to moderate, but not much. It's okay. I could have left this child. If any clinician Oh, this is okay. Primary teeth will not 2 to 3 mm. Even your model analysis say 2 to 3 mm, you can leave it. I would have done that. But functional analysis, make sure the child is having a functional problem, which you never know how it can come. You cannot leave this kind of case. This case is not review. This case, you have to act. So best appliance for this would be a modified functional appliance which is given to her. That is, and so FR1, functional regulator 1, for mild to moderate crowding with functional problem to correct the myotherapy, the tongue training and all those things has been done to her. So this was the appliance given to her. And last 6 months, now it's lockdown time, I have not seen her. Last 6 months, the latest picture for her is, you can see how nicely the arch is, and now only space for one side canine which is coming buccally, which you can put nicely aligned with a wire. And lower arch, can you see the lower arch? It's almost one wire, one leveling and alignment will make a perfect position of the tooth. That's the beauty of functional appliance at the right time if you give. Or there are appliances like pre-orthodontic trainers are there. That also is wonderful. You can give that also. That's also a good appliance where I also specific conditions give functional appliance, functional therapy with trainers also we give. It can also do a good job. But functional problem, mild to moderate crowding with functional problems, we can give this appliance. So the identification of the functional problem is very important. Now, moderate crowding. Imagine patient is having your model analysis says that patient is having a moderate crowding. Can you do that? So again, functional problem has to be that moderate crowding cannot be just happening. There can be other reason for that. But functional problem has to be done. That lower anterior crowding could be a lip busting, lip biting, muscular activity, which is called that you have to identify that, or any habit or anything will be present. You have to find out that. So once you find out, once you correct that, then it's so easy that you can use expansion appliances because it is moderate. You can't relieve that crowding by itself. That's not going to happen with functional appliances. Better you go for expansion appliances because crowding is almost to the moderate to severe category it is. So you can expand the arch by transverse with slow maxillary or mandibular expanders at early age. You can do because all are your dentoalveolar expansion, transverse expansion, what you are doing, or dentoalveolar expansion. So slow maxillary or mandibular expanders you can do, or even you can do rapid maxillary expansion also, especially the maxilla, and the mandible can follow. Severe condition you can do rapid max expansion also. So all are transverse expansion you can do. So slow max expanders, your removable slow max expanders or a fixed slow max expanders, which are banded expanders are available, which you can do. So the most common thing which I use, around 70 to 80% of the cases are done with slow Schwartz expanders, which are there. This is my favorite. One of the favorite appliances which I use is slow Schwartz expander, which is a Roberts retractor. Many of the conditions I can manage with this appliance. Patient compliance and cooperation is very important for this appliance. Expand the arch, provide the room. If mandible is maxilla expanded, mandible will follow there. So this expansion, right? So how many turns in these expanders you have to do? One turn per week or 2 turns per week, depending upon the condition. Depending on the condition, you do that. Treatment is completed by 2 to 6 months and just use same appliance sealed as a retainer or a fabricate another appliance as a retainer. Exactly like after orthodontics, you give a retainer there. So how to do that turnings is very simple, easily applicable to you in your clinical practice. Parents are happy to use that because they are so comfortable with this doing the turning. All those 1 turns or 2 turns in a week, so simple. The appliance is hygienic it is because it is removable. Patient can maintain the hygiene also. So a case, their parents came with a crossbite with the resorption. We explained to them that we need an expansion, but they did not take any treatment because the lateral is not being seen. So we told them, but they did not take up any treatment. After a year, they came back with the lateral coming inside. Then they said, sir, we want that teeth as more crooked, the teeth is coming. So we expanded the arch. This was the initial condition. The first and 1 year after the second condition, then we expanded. Slow maxillary expansion, guided eruption we gave, and recently you can see the recession, everything is gone. Natural midline, natural guiding of the arch, slow max expansion, around 2.5 to 3 years of follow-up is required for this case, and you can see what amazing result it can become. You don't feel like putting a archware in the lines, automatically will settle down by itself. It's a wonderful appliances, slow max expanders. Now, I'm going to put up a case. All of you, please come to the chat box and say, what is this? What is your treatment plan for this 7.5, 7.8-year-old female patient? Please come to the chat box and tell your opinion of treatment for this girl. 7.8, almost 8 you keep it here. Almost 8 you keep it. What is your treatment plan for this female patient? Please come to the chat box and tell me what is your treatment plan. What is his condition and what is your treatment plan? 7.8-year-old female patient. Okay. Over-retained, fine. Over-retained, fine. Retain one. What will be your treatment plan? Can Yukti Gupta and Dr. Sapna, can you tell me what will be your extraction? Fine. Extraction. Extraction of 111. So this has happened. This has happened to me. That's what I put this picture. This case, what will you do? Fine. That's great. See how you have changed your perspective of treatment. I did not do extraction for this. I did not do extraction for this child. Okay. You know what I did? What you said. What you said is partially correct. I did not do extraction for this child. I told them fine. The tooth has not come. The child is almost 8 years of age. It's about a year, one side tooth has come. I told them, you take an OPG. You take an OPG. You take an OPG and come to me. I want to know, sorry, take an OPG and come to me. I want to know whether the central is already present inside. See, 7.8, almost 8 years of age, the central, the primary central is still there and not much mobile. Not normal mobility, not much mobile. And how can I just remove it and say the blind is, oh, it will come inside. If you're lucky, it will come. If the central is missing or anything happening, how do you know? So I told them to take the OPG. Look at the OPG of this. Look at the OPG of this. Can you tell me what is there in the OPG? Can you come to the chat box and tell me what you find in this OPG? Just see the OPG closely. Just see the OPG closely. What do you find in the OPG there? Tooth size discrepancy, fine. Dr. MT, I don't know, your name comes as MT, sorry. Dr. Pramod D57 says that size, okay. Jennifer G, root formation, fine. Anybody else? Anything else? That is true. I can understand that because we tell the patient when to indicate OPG, why to indicate an OPG. I'm getting a lot more response. Non-vital, want to do the impact of trauma, tooth size, rotation of the lateral space, loss, tooth size, will see fine. So the issue is whenever we indicate an OPG, when they bring an OPG, the OPG looks like this to us, like a neurosurgeon looking into an MRI scan. What to see, where to see, how to see. So you and your patient will look into each other. What will I tell? What will I look? Okay, tooth is retained. Okay, I will remove that. That is it. That is the beauty of this. Now, look into this OPG. The root of the primary central is not resolved. The root of the primary center is till 10 mm not resolved. So the primary permanent teeth is gone somewhere. It's a two-dimensional picture. You can't tell them to take a CBCT. You can't tell them to take a CBCT and say, decide the position of the permanent and primary teeth, the gap between both of them. But look into the root tip of the primary teeth is not resolved. So that means the permanent teeth is gone somewhere. Either palatally, buccally, you don't know, is gone. and the lateral incisor is ahead of the central. Lateral incisor of the same side is ahead of the central. That is why space is lost there. So lateral is going to come into nice place, and that central is going to get blocked out or coming to buckly out or wherever it is. That is the beauty of an OPG. Reading of an OPG is an important task. Immediately told them to remove that central. I have to remove the central, but that is not enough. I told them you need expansion. I don't need here any model analysis to ascertain that this much discrepancy is there so that I am expanding. Please, this is an evident because already the lateral incisors started rotating. Space is deficient there. With an evidence, you can see that space is deficient there. So just to promote that, slow maxillary expansion has been advised. That is what slow maxillary expansion is a wonderful tool that you have to learn. Either removable or fixed slow maxillary expansion can bring a lot of goods and deed in your practice there. Especially quad helix is an amazing appliance that expand dental and little of skeletal. If you do it early, we can bring out. So quad helix is an amazing appliance that you can give, which can bring out dental, and some early if you apply skeletal expansion can be done. Amazing result with quad helix and straight where simultaneously you can start. That's the beauty of this appliance. If you give an arch where I can't even take a picture, expanded with the quad helix from inside, started straight from outside, finished it with non-extraction protocol. This. Now imagine if the patient is having a severe crowding. I'm almost done. 5 more minutes, I'm done. Severe crowding of more than 6 mm. Crowding, severe crowding is there. The option would be a rapid palatal expansion. More than 6 mm to 10 mm would be a palatal expansion. So palatal expansion is like hyrax bonded, hyrax banded are there, which can be give tremendous result in your practice. Just want to show a case where child is not indicated for a or for extraction because of the arch was so constricted and dished in it was. You can't extract him and correct that crowding there because of the indicators are all for constricted arch. Profile, extraoral, intraoral, everything is saying that, but discrepancy is around 8 to 10 mm discrepancy of the arch. So rapid maxillary expansion, 4-point rapid maxillary expansion has been done with the hyrax, align the arch, nice result we can get with that. That's a permanent dentition. Now what about the mixed dentition? Identified early severe space problem in a mixed dentition condition. Huge size arch, expanded the arch, and you can see the lateral is automatic. I did not do even bracketing here. Please look at that. I did not do bracketing here. What I did is allowed the nature to compensate. Expanded, hold it, the nature took care of that. That ugly duckling, all those things nicely followed. But when you use rapid maxillary expansion, you should never forget this slide. Please take a screenshot of this slide. This is very important. What has happened here? I did a rapid maxillary expansion, but this is not unsuccessful. It's a failure happened because parents did not report. They were not motivated to report. They were very enthusiastic in the beginning, but they lost interest or they had some other difficulties. They did not come. What has happened here? They turned the screw at their will and wish. They did that, but totally collapsed. Scissor bite, scissor bite. After an year, I seen that. Oh my God, this has happened. Because rapid maxillary expansion, if you do, there should be a midline gap should follow. After 3 to 4 days of expansion, there should be a midline gap should be followed, and you should take an IOP and see that mid-palatal suture is split open. If that is not split open, do not continue that. It's a failure. So that is what happened. This is a patient did not return back because it's not anticipated in such a way. It can happen in your general dental practice. Always make sure when you are giving rapid max expansion, you need additional protocols to find out how it is functioning there. So other options other than this is serial extraction or plant extraction of some deciduous teeth followed by the permanent teeth would be other option. Or leave it like that and 13 and 14 years go for all for a bicutis extraction. That could be another option. I just want to wind up with one case, a patient reported with 11 years of age with complaints of anterior procline teeth. The complaint is teeth are coming out. And if you see the picture, you can say that yes, the teeth are coming. 11-year-old female. I saw that this is a picture. She has got chromogenic stain. You know, the chromogenic stain is there. So this is an intraoral picture. And yes, we do that. The rickets E line, yes, both are coming out. That's true. This is upper arch and the lower arch. You can see the chromogenic stain. Now, can you compare between the upper arch and the lower arch? Okay. Can you come to the chat box and say what difference do you see in the upper arch and the lower arch? Can you see any difference? Is the 11-year-old female? If you can say that, I think I am successful in this. Just look into the upper arch. 11-year, again I'm telling you, 11-year-old with proclined teeth is the complaint of the parents. This is upper arch and this is the lower arch. What? Yes, canine. Yes, canine. Yes, canine. No permanent canine? No. No, that is not that. So if you can see 11-year-old upper canine is still in, that is good. Retained 3, you can say, not 4. Retained 3, you can say. That is a good thing. You can see that upper canine is 11-year-old, it is not gone. Lower canine, one canine is gone. Other side canine is still present there. So when I saw this, let me tell you frankly, when I saw this, I related to my daughter. My daughter is also 11 years of age. Her all canine is gone. All canine is gone and the permanent canine has come. First premolar has also has come. And she's also 11 years of age. I can see that upper canine is still wood and hard. It's not even mobile. Lower canine, one is gone, other side is started mobile. There is something wrong. I told madam, I need a protocol. Can you do that? So I told them I need an OPG because the gap and everything is there. You know, the midline diastema, ugly duckling is 3 mm gap at 11 years. That's not nice. So I asked them to take an OPG. When I saw the OPG, now can you look into this OPG? Can you tell me what you find in this OPG? Please look into this OPG and tell me what you find. Same patient OPG. Just take your time. Take your time and tell me what is in this OPG. Look at very closely. Space loss in lower, fine. Rotated canine, empty as a rotated canine, fine. Buccally position maxillary canine. Well, you can't say buccally position because in OPG. Dr. Jonah Biswas. Great, 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 great. See, here is the OPG. The ruler here is OPG. The lateral incisor, root tip, and the canine are not good. Ugly duckling should be where? Where is ugly duckling? When the canine tip touches the root tip of the lateral incisor, the lateral incisor goes distally and central incisor go distally. But here the canine is gone beyond the root tip of the lateral incisor, but still that gap is there. So that made me to take this OPG. Immediately what I did is I removed. If I did not do anything, it will come like this. If I do not do anything at this point of time, it will come out like this. So what I did is I removed the primary canines. Both the primary canines, I removed it. Look at the primary canines. What is the length of this primary canines? You know, it's around 19 millimeter. 19 millimeter, 11 years of age, not resolved. I can give to tooth bank. The pulp is vital. I can give the tooth bank. Entire canine is not even resolved. So the permanent canine, where it is gone somewhere. So I removed both. That is the planning that you require. So the first sign is not OPG. The first sign is clinical indication that is being done. Then plan for rapid maxillary expansion. Whatever some people said that, yes, there was space deficiency, rapid maxillary expansion. Now she's under retainer with almost no brackets in this. No bracket in this. Almost finished. Going to finish. Premolar has to come. She's on 12 years of age now. Premolar has to come. So guys, where are we? Where are the steps leading to us? Are we stagnant in our clinic, or we want to go up, up, up? It's decision issues. Learn more. Spend, learn, and accumulate the knowledge that can change your practice. Apply it. Learn which you can apply that can change your practice. So we are coming up with tomorrow with an amazing session by Dr. Binu, must attend session which can change your practice in a drastic way. Thank you so much. You can follow us in Facebook, in your page or a group, Insta. This is my WhatsApp number, my email ID, or you can log on to learn.onlinedentistry.in and you can go. Thank you so much for your patient listening. I think I have taken, yes, almost perfect. I give 5 minutes extra, 45. I start 1 hour. Done. Dr. Minu?
Thank you, Joby.
Yeah.
Yes, Joby. Thank you so much. As we expected, it was definitely different from what you did last time. So, guys, there is a continuation tomorrow. As Dr. Joby might have already told you, there's a continuation tomorrow. So let's take some questions, Joby.
Yeah.
Saul, thank you, thank you, thank you, thank you.
So please do come to the, please you can come to the WhatsApp group and you can,
Dr. Joby, you have just ignited a spark there, yeah? The spark. No questions. It's all thank you very much. Great session. Thank you, thank you. Yeah, we have a question here. So what do we do in a 5-year-old child where we see no non-space dentition and little crowding in lower anterior? Yukti Gupta in Zoom.
Okay, that's a great question, doctor. That's what exactly I told you. If you find there are no spaces in a 5-year-old child, so no spaces means there's a high chance of crowding in the permanent dentition. So there are something called function analysis to find out the food habit of the child, the swallowing pattern, muscular activity, a lot of things that are there, like breathing, like mouth breathing habits, tongue posture, all those things are one factor you have to take care about that. If those things are there, start with simple exercises. No, you cannot institute everything for every child. You have a different philosophy. Some patients and parents are very willing. You can give some kind of trainers, some kind of appliances which they are willing to do. So appliance and but exercises or myotherapy will help you. There are some patients with parents or patients are not willing. What you do them? That is a big question. What will you do to those parents and patients who are not willing? Keep them under observation, motivate them, talk to them, give some gift, and slowly mold them. When they become at least 7.5 years of age, they might accept you. Do not worry, growth still remaining. You can do wonders there. So, basic thing is observe, keep them observation. If they're ready to accept the treatment, not to accept the treatment, keep them under observation. Those people who are ready to accept, start implementing myotherapy, your functional appliances, you do that. Those people are not ready, keep them observation. Under 3 months, under 6 months, motivate them, and they will come back into track.
In 8-year-old, if we see lower anterior crowding, should we give lingual arch to prevent late mesial shifting of permanent molars? Can we expand lower arch? Sonal Kasturi.
Yes, in an 8-year-old, if you see lobar area crowding, you should not be worried much about the posterior segment. Doctor, your entire question or entire preferred mode, what you said is of preserving the posterior segment. What is the posterior segment has is a leeway space. So you are trying to give an appliance to preserve the posterior segment. Let me tell you, in an 8-year-old, first and the foremost thing that you have to see is what is happening in the anterior segment. Why the space is getting lost or crowding is happening in the anterior segment. It could be due to of a hyperactive mentalis muscle or something, some kind of habits. You correct that. Tongue is not at proper position or lip or anything. Perioral muscular activity, simple tongue thrust and complex tongue thrust. You know, there's a lot of difference in between simple and complex tongue thrust. The amount of pressure exerted by simple tongue thrust and a complex tongue is different. So all those things, if it is present, it will be very blunt, or we can say a tie of effort from your side to just to preserve the space for the posterior segment. If you're happy, if you're lucky enough, the lingual arch might use that leeway space and you get some amount of space. But still, that anterior component problem can lead to late anterior crowding. Like you aligned everything, perfect everything, but 23, 27, you can see the second molar and third molar eruption. You can see again the crowding is reappearing because the anterior component you did not address. So address holistically.
Whether trainers are really useful.
Trainers are useful. I am not against trainers, but patient selection is very important. Patient selection is important. I am getting per day 1 or 2 cases with failure of trainers also. What is the reason for the failure? It's not because of the appliance, because they selected the wrong patient. Trainer getting teared off, patients not uncomfortable wearing this. A lot of things are there. Any appliance you talk about, either removable or fixed, there are issues. There are issues. So philosophy, if you want to say, you have to collect and talk it together, especially it is a myofunctional appliance. So in Sunday, I'm giving a webinar on myofunctional where I'm going to talk about patient selection, whether it be a trainer, fixed, or your removable, how you have to manage. I'm going to discuss about it. But all are good appliances provided you select and diagnose correct and select the correct patients. All do good job.
Is there any chance of hereditary class 3 malocclusion? I mean,
100%.
skeletal.
Yes. There are definite methodology to find out a true hereditary class 3 malocclusion, especially class 3 malocclusion. That is history, facial profile, and cephalometrics. The three has to come in together. What is that? History, your facial profile, and cephalometrics. If three united, plus, if it comes, it is hereditary. So there's a composite analysis for that.
Why are mesiodistal dimensions of permanent mandibular central and lateral incisors mostly taken for model analysis, and which analysis to be done in crowded deciduous dentition? Dr. Rishabh Kapoor.
Yeah, first question is what, Dr. Binu, has lower central and lateral, right?
First question is why in almost all analysis the lower central lateral taken as the most, because that is the most stable one. Yeah, the upper central lateral, we always having a dimensional instability, all that lateral and all that. Dr. Joby, I'm just saving your time and your energy. That's all.
Yeah, that's all. That's very true. The variation, the mesiodistal variation of lower central are more stable. Missing tooth kind of shape, all are better. And second question is primary. Any
the
analysis?
Second question is which analysis to be done in crowded deciduous dentition?
I already gave you the analysis, Dr. Binu. I think I have given you the analysis without anything. If there is a crowding in the primary dentition, 10 out of 10 cases, the permanent dentition, there will be crowding. There are no primary dentition analysis available, but if there is a crowding in the permanent primary deletion, there is a 10 out of 10 cases of crowding in the permanent. But if two central incisors are erupted, permanent central incisors erupted, then the lateral incisor, the side by side lateral incisor, has to be taken with an OPG or your OPG with your X-ray analysis has to be done. That's all.
Joe, please take up questions from YouTube, please. Dr. Joe, please take up questions from YouTube. So meanwhile, let me just take one more question from the Zoom. Dr. Chetan has asked, sir, I have seen my child, 2 years, tendency of biting in class 3 position in anterior cross bite, especially before eruption of second primary molar. Question not very clear. Sir, I have seen my child 2 years, tendency of biting in class 3 position in anterior cross bite, especially before eruption of second primary molar.
Now I want to ask the same patient, what is the situation now? After the eruption of the second molar, what is the eruption? What is the bite?
Dr. Chetan is actually talking about his own child who is 2
Yes,
years old.
now what is the bite? Before
And the
eruption,
kid bringing forward and
yes,
biting all the time.
yes,
That's what he's talking about.
I understood, but I just want to know that.
Yeah, but he's not to be seen anymore for any more.
Yeah, because with Dr. Binu, because what happens is when there are no molar, so they can bring the tooth forward. That happens.
I know.
And once the second permanent molar comes, they usually revert back, provided if there are no sharp lower canines. If the lower canines, primary canines, are very sharp, they can still bring it forward to get the functional occlusion. To get the occlusion, they will bring it forward. So
Yeah,
you might have to selective
that
grinding of the
doctor
lower
has to come once more on that. Hey, Dr. Chetan, thumbs up. Yeah, I'm going to unmute you. Why don't you talk? Dobby, can we take your voice?
Yeah, I'm done. I'm done.
Dr. Chetan, I'm trying to unmute you. Yeah, go ahead, talk.
Yes, sir. He's still 27 months, and the question is that he's getting erupted to second molar. He started erupting. 7.5 is erupting, but I want to ask, it is generalized habit of kids.
Dr. Chetan, yes, Dr. Chetan, one thing I would just look into the child's primary canines, lower canines and the upper canines. Just look into, are they sharp or not? Just look into that. Okay, one thing. Second thing is, what about a child is having hard food? That is, the child is taking some kind of hard food or still under soft food or not. So I think you have your contact number. My WhatsApp number is you can contact me personally. We can discuss that.
Yeah, this is actually a personal stuff. 2-year-old is actually a personal stuff. So please feel free to talk to Dr. Jobby or chat with Dr. Jobby regarding that. Fix up a time to talk to him, and I'm sure we can definitely answer that, right, Jobby? It's a very genuine doubt from a 2-year-old kid's father. So we have to definitely answer that. This is not a dental.
We can do that
thing. Yeah, definitely. Joe, you want to take a question from YouTube? You want to do that?
Yes, sir. Yes, sir. Yes.
Go
so
ahead.
We have a question from Dr. Bindu, and the question is: 8.5-year-old till no primary teeth is mobile, no permanent erupted yet. So what should be done?
Oh, 8.5-year-old. Again,
question.
it's a very if I have to talk about this, is a pretty long question. But first and the foremost thing is, doctor, 8.5 advise an OPG first and a blood test of calcium and vitamin D3. Okay. So again, this is personally you require a little more follow-up for this case. I need to ask you some kind of history, some kind of questions. If you know my WhatsApp number, just put in chat. I can fix a chat and I can guide you, because little more things are required. History is required for this question. But right royally, 8.5, 8.5, you please advise an OPG then I'll advise you the next step, how to proceed.
Yeah, and the lockdown effect last 8-9 months has brought down the vitamin D levels of all these kids. So please go ahead, do the blood test also.
Yes.
Angel and Mudichu, two people asked lower anterior proclination with recession. I don't know whether that's a question. It's just written lower anterior proclinations with recession.
Yes, lower anterior proclination. If there is a lower anterior proclination is there, there will be recession of the lower anteriors will be there, because the gingiva goes down when the tooth comes more labily, and that's one of the sign of lower anterior crowding.
What condition or how to select a trainer? How long to wear? Balaji, Dr. Balaji.
Dr. Balaji, that's a question. How
That's a 3-day
program.
topic.
3-day topic to tell. That's a simple question you ask, which all cases you can select for trainer. So I just showed you one condition where you can select trainer is mild to moderate crowding with functional problem like tongue thrusting, mouth breathing on that. Now next is how long to wear. Where that is like all through the night and 1 hour per daytime. All through the night, 1 hour through the night means sleeping. Minimum 6 to 9 hours and 1 to 2 hours in daytime, that will do that.
Joe, any question from YouTube?
Yes, sir. We have one more question. Sir, it's from Dr. Bharat Vardhana. The question is, sir, a 13-year-old male patient with retained upper canines, maxillary excess, mandibular deficiency, class 2 MO, moderate anterior crowding in the upper. Where do I begin?
Oh, this can give you our archival analysis would be the best. To start off with a high pull headgear in the upper and the chin block with the headgear, that kind of
No,
things.
but one second, Joby. I heard something called retained canines. Joe, just say that again.
Sir, yes, sir.
I heard something called retained canine.
Yes, sir.
No,
upper retained canine, sir. Yes.
You mean Decidus canine retained?
Yes, has to be.
The SEF and OPG is mandatory before start off.
Very difficult to comment. We are talking about Decidus canine retained at the age of 13 years. We are talking about both the transverse as well as sagittal put together. Right, Joby?
Yes, Vinod. OPG is a mandatory, at least an OPG and SEF and the analysis. And the 13 years, I would say that I will go for the archival analysis. That's the one that I follow. Sassonis or modified Sassoni plus put the one that I go for to do any further treatment protocol for that. But that retained canine is worrying. You can see that canine will be sleeping inside. The permanent canine will be sleeping or will be in some other position. So you have to take an OPG or a CBCT after depending on the OPG. What do you say, Binu?
Yes, yeah, it's both transverse sagittal issues together. I mean, there's a transverse issue because canine hasn't come out. There's a sagittal issue because there is a maxillary excess. So we got to deal with both. So self-mandatory. That's a personal question. I would feel you got to come personally into our WhatsApp. We will discuss. No issues. Okay. Joe, any more questions from YouTube?
No, sir. That's also 2 questions, sir.
That's it. So Zoom questions also done. But please, guys, if you're in our WhatsApp group, feel free to put your questions in the WhatsApp group. Please feel free to ask any of these doubts in the WhatsApp group. We will definitely answer. Those who are not in our WhatsApp group, please note down our WhatsApp numbers. Joby, your slides are still there. You want to go back to your WhatsApp number?
Yeah,
That's 94463 21220 or 98470 or 32. One of these numbers you can put a WhatsApp. We'll add you now WhatsApp groups so that you can get all the updates. Meanwhile, you can go to learn.onlinedentistry.in and get all the details about the coming up programs. Tomorrow, there's a little bit of continuation of tonight. How to correct these small diastemas. How to correct the small single tooth cross bites. More predictable will be covered tomorrow in the sectional orthodontics part, which is happening tomorrow 9:30. See you all tomorrow. Thank you very much. Jobby, can we call it a day?
Yeah. Good night.
Thank you very
Good night.
much.
Yeah.
Good night all. Good night.